All right, well, let's get started. Got a lot of material to go over. Um, Final reminder that that link is in the chat box. If you want to finish that before we get into the meat of the presentation, please go ahead. I do want to welcome everyone on behalf of Project First Line Rhode Island and the Center for Acute Infectious Disease Epidemiology at the Rhode Island Department of Health. We're in partnership with the CDC. Thanks for taking the time out of your busy day to join me to talk about measles in a healthcare setting. We're going to review some important infection prevention and control strategies today that I hope will be helpful to all of you. Today's session is a repeat. We initially launched this webinar about 2 years ago, but given the current measles situation in the United States, we felt like it might be worth offering it again today. Before we begin, I would like to direct your attention to the chat and introduce Abby Anderson, who is our Project First Line Rhode Island project assistant. Abby will be posting information for you throughout the webinar via the chat. As a reminder, the session is being recorded. The Project First Line team is behind the scenes today supporting this webinar. If you'd like to take a minute to introduce yourselves in the chat, telling us your name, where you're coming from, we'd love to meet all of you. My name is Alexis Kearney. I'm a practicing emergency medicine physician here in Rhode Island, and I serve as the consultant medical director for Project First Line Rhode Island. Prior to attending medical school, I completed my MPH in the epidemiology of microbial diseases and have experience responding to outbreaks in infectious diseases in the United States, Asia, and Africa. I'm excited to see all of you here today speaking with you about measles and what all of us can do to help prevent its spread. So glad to meet everyone. If you're returning, glad to see you. If it's your first time at a Project First Line Rhode Island webinar, thanks for being here. Happy you're all here and able to join in the session today. A few quick reminders before we dive in. Currently, everyone is muted. At the bottom of your screen, you'll see the Q&A box. You can use this for all questions. We'll try to have a brief question and answer session at the end and try to address any of your questions, provided we have the time to do so. But if not, be sure to leave your email and we'll respond to any questions that you may have now that we don't get to or anytime after the webinar as well. The chat box is available to connect with our behind the scenes team members, and we'll be using the chat to share experiences and interact throughout the session. All right, so here are the continuing education criteria for those of you who are attending and would like to receive CNE credit. The session is approved for 1 contact hour by the Northeast Multi-State Division Education Unit, an accredited approver of the American Nurses Credentialing Center Commission on Accreditation. To receive your CNE, there are 4 steps that need to be completed. Step 1, if you haven't already done so, please complete the pre-session survey prior to the start of this training. The link was in the chat. Go ahead and take a moment to finish that up now because it does start once we get into the meat of the webinar today. Step 2 is attending this entire training, which you're already here. Step 3, you're going to need to complete the post-session survey after this training ends, and that will be emailed to you tomorrow. And then there's also a post-session quiz, that is step 4, and this will also be emailed to you tomorrow. For other healthcare colleagues who are here today opting for certificates of training, EMS continuing education, and dental IPC continuing education, you just need to work on steps 1 through 3. Step 4, which is the post-session quiz, is optional. All right, quick submit on all of those pre-session surveys, and we'll get into it now. So while measles was once considered to be eliminated from the United States, we have seen a sharp increase in cases over the last 2 years. Overall, there's been a decrease in vaccine uptake nationally, which puts more people at risk of contracting the virus. Back in March 2024, the Centers for Disease Control and Prevention issued a Health Alert Network health advisory to inform clinicians and public health officials of an increase in both global and US measles cases and to provide guidance on measles prevention. Measles, as many of you already know, is a very contagious viral infection that causes a total body rash and flu-like symptoms. It spreads easily and can be serious and even fatal, particularly for small children. Outbreaks of measles in the healthcare setting do occur, and transmission to and from healthcare professionals continues to be reported. Healthcare professionals are considered to be at higher risk of contracting measles than the general population due to the fact that patients with measles often seek medical care due to the severity of their symptoms. And furthermore, given how contagious measles is and potentially under-recognized, it leads to delays in patient isolation as well as diagnosis. Today, we're going to really focus on a review of measles to start with, and then the infection prevention and control strategies that you can take in your healthcare role. So our agenda for the day, we've already done our welcome and introductions. Next, we're going to review the learning objectives for today, focusing on the history of measles and a clinical overview. The second half of the webinar, we will focus on vaccine recommendations, infection prevention and control actions, and go over a few case scenarios before reviewing our key takeaways. At the end, we'll have a few moments for announcements, give you a chance to provide end of session feedback, and then hopefully have a few minutes for a brief question and answer session at the end. So what are our learning objectives for today? We have 5 of them. First, understand what measles is and learn about its resurgence in the United States. Second, learn how to rapidly recognize measles based on history and clinical presentation. Third, understand how measles spreads. Fourth, know the steps to take if there is an exposure with and without proof of immunity. And number 5, learn the infection prevention and control actions to help decrease the spread of measles. So let's first take a few minutes to review a brief history of measles in the United States and discuss the current state now. So before the live measles vaccine was licensed way back in 1963, there were an estimated 3 to 4 million people infected with measles annually in the United States. However, most of these cases were not actually reported to health officials. Historically, measles was a childhood illness, and most people contracted it by the time that they were 15 years old. It has been a notifiable disease, a nationally notifiable disease in the United States since 1912. But despite this, only around 549,000 cases of measles were reported to health authorities annually. Of these, about 48,000 individuals required hospitalization, 1,000 developed acute encephalitis, and on average, between 400 and 500 people died annually from measles. In 1968, an improved live measles vaccine was licensed, and then in 1971, the MMR vaccine was introduced. So MMR stands for measles, mumps, and rubella, and provides protection against all 3 illnesses. Fast forward to 1989, the United States and other countries around the world saw an increase in cases due to low vaccination rates. This was really due to vaccine hesitancy linked to widespread misinformation about the safety of the vaccine. In 2000, after significant work by public health officials to increase vaccine uptake, measles was actually declared eliminated in the United States, and we'll talk a bit about what that actually means in the next slide. But since 2000, the annual number of cases has ranged from a low of 37 cases in 2004 to a high of 2,284 cases last year in 2025. The majority of cases in the United States over the last 25 years have been among individuals who are not vaccinated against measles, and most were linked in some way to imported cases of measles. So this means that an individual contracted measles while visiting another country, and then when they return home to the United States, the measles virus spreads amongst their friends and family and other contacts, generally to other unvaccinated individuals. Since measles is so contagious, it quickly and easily spreads in communities with large groups of unvaccinated people. And over the last year, we've seen a significant increase in measles cases across the country, leading both epidemiologists and health officials, and many of you as well, to worry about sustained measles transmission in the United States. So the World Health Organization defines measles elimination as the absence of endemic measles virus transmission in a defined geographical area for at least 12 months or longer in the presence of a well-performing surveillance system. So measles was initially declared eliminated in the United States in 2000, meaning that there was no measles virus spreading within the country And new cases were only found when someone contracts measles abroad and then returns to the US. And this was really a testament to the widespread vaccination campaigns that were done by public health officials, both in the United States and around the world. However, travelers do continue to bring measles into the United States, and it can sometimes spread and cause outbreaks among other individuals who are not vaccinated. So, while the term elimination doesn't mean gone forever, the rapid rise in cases over the last 2 years poses a threat to the United States losing its elimination status. So, why are we talking about measles? Why have we been seeing it kind of around the news and the media? And why are we worried about it? So, a decrease in measles vaccination rates globally directly results in an increased risk of larger measles outbreaks worldwide, including in the United States. And why is that? Let's talk about kind of what an outbreak actually is. So, an outbreak is when a disease occurs in greater numbers than expected in a particular area. As we've talked about, we are seeing increased outbreaks amongst people who are unvaccinated. And as we talked about, measles is often brought into the United States by travelers who contracted the virus while outside of the US on vacation or visiting family. When a measles occurs or when it enters into communities of unvaccinated people in the US, outbreaks can and do occur. And outbreaks in countries in which Americans often travel to can directly contribute to an increase in cases in the United States. So, over the last few years, measles cases have been linked to travelers from frequently visited countries, including the Philippines, Ukraine, Israel, Thailand, Vietnam, England, France, Germany, and India. And there have been large outbreaks reported in these countries as well. So this is a slide showing the number of measles cases reported by year in the United States. As of March 12th of 2026, when I pulled the data, there were 1,362 confirmed measles cases across 31 jurisdictions in the United States since January 1st of this year. There's been a total of 14 outbreaks, which is defined as 3 or more related cases reported since the new year, and 94% of confirmed cases, so almost 1,300, 1,281, are outbreak associated. So for comparison, there were a total of 2,284 confirmed measles cases last year in 2025, and there were 48 total outbreaks, and 90% of the cases were outbreak associated. So of the 1,362 cases this year, about 22% were under the age of 5, 54% were in the 5 to 19 years group, and 23% were greater than 20 years old. 1% we didn't know their age. The overwhelming majority, about 92%, were unvaccinated or of unknown vaccination status. 4% of individuals had 1 MMR vaccine dose, and 4% had 2 MMR doses. 5% of cases have required hospitalization, and thankfully, we have not yet had any deaths from measles this year. So this graph reflects the number of measles cases reported in the United States, broken down by week, starting in 2023 through March 12th. As you can see, in January 2023, there were very few cases reported each week. We started to see a small uptake in 2024, and then significant increases since the start of 2025. These are the 31 jurisdictions that have reported cases since January 1st, 2024. The darker the blue, the more cases have been reported in that area. So this brings us to our first poll question. I invite everyone to participate and enter your answer in the chat. They're anonymous, and we'll talk about the answer in a minute. Great. So the answer for that one is decreased vaccination rates. Yeah. This is what's been resulting in increased cases globally. Great job. All right. So we're going to next talk about a quick clinical review of measles. Some of this information may be old for some of you, depending on your role in healthcare. So one of the most important things when thinking about measles is the timeline. And this is an essential piece of information to collect when suspecting measles in one of your patients. Um, After exposure to the measles virus, there's an incubation period of 10 to 14 days during which during which time the exposed person is asymptomatic. They have no symptoms. Around day 2 to 4, prior to the onset of rash, so 2 to 4 days before the rash starts, the prodromal symptoms begin. So this includes fever and at least one of the three C's, cough, coryza, and conjunctivitis. So following the onset of these symptoms, the rash begins. The date of rash onset is considered day 0 when talking about measles cases. On average, the time from exposure to onset of rash is about 14 days, and the longest time period that's considered is 21 days. So people who develop measles are considered contagious from 4 days before to 4 days after the onset of the rash, which is one of the things that makes measles really tricky. This informs isolation and exclusion policies for those who develop measles, this period in which they're contagious. And the challenging part really is the fact that the challenging part of measles control is the fact that people are infectious before the rash and can be infectious when they only have really mild, non-specific symptoms that look like other respiratory illnesses. So the common symptoms for measles. So we need to have a fever. It can be really high. It can be 104, 105. And then the three C's. So we see cough, coryza, which is runny nose, and conjunctivitis, so red, watery eyes. We have the maculopapular rash, and then patients can develop white spots or dots inside the mouth, which are called Koplik spots. This is an image of the Koplik spots. They're characterized by clustered white lesions that appear inside of the mouth. They appear 2 to 3 days after symptoms begin, and they are sometimes described as grains of salt on a reddish background, and they do occur prior to the skin rash. So the rash, everyone's favorite. Let's talk about the characteristics. So it starts at the face, at the hairline, or behind the ears, and spreads downwards to the neck, trunk, and extremities. It's maculopapular, so that means small, raised, or flat bumps. And these spots might become joined or coalesce as the rash spreads. And it's usually not itchy. And then it fades in the same order in which it appears. So this brings us to our next poll question. What is the typical presentation of a measles rash? So A starts at the trunk and then spreads up to the hairline and extremities. B starts at the extremities and spreads everywhere, including the palms and soles. C starts at the hairline or face and then moves down to the trunk and extremities. Or D, rash appears in no pattern. Awesome. So the answer was C, starts at the hairline or face and then moves down the trunk and to the extremities. Okay. So complications from measles can arise in individuals. The most common complications are diarrhea, so otitis media, which is a middle ear infection, and pneumonia. These complications can cause substantial morbidity and in some cases mortality. In particular, measles pneumonia, which can cause severe illness in infants and other immunocompromised individuals. The most severe complications can result in hospitalization, which occurs in about 1 in 4 cases of measles. Encephalitis occurs in about 1 in 1,000 cases, and death anywhere from 1 to 3 per 1,000 cases. All of these complications are more common in 2 age groups, those under the age of 5 and those over the age of 20. The most complications are amongst individuals not vaccinated against measles. I also wanted to draw your attention to the last line on this table, which is a delayed complication. So that means that it happens well after recovery from the virus. So subacute sclerosing panencephalitis, this is very rare. It occurs anywhere from 1 to 11 per 100,000 cases. SSPE is very devastating. It's a neurologic complication that occurs about 7 years after measles infection. and it is more common in individuals who develop measles less than 2 years of age. SSPE is a progressive neurologic decline, which generally leads to death in about 3 years after its onset. So once a person has clinical symptoms of measles, unfortunately, there is no specific treatment other than supportive care. So there is no particular antiviral therapy for measles, and we use supportive care to relieve symptoms and address complications. Severe cases, particularly among children who are hospitalized, can be treated with vitamin A. This is typically administered on the day of diagnosis and then repeated the next day. But in cases where there is also vitamin A deficiency, a third dose can be administered. We can use post-exposure prophylaxis in some cases, though. And this can be given if we're within a specific targeted window and may provide measles protection or shorten the duration of symptoms. So individuals exposed to measles who cannot readily show that they have evidence of immunity against measles should be offered post-exposure prophylaxis. So we have two options in this case. We can either administer the MMR vaccine within 72 hours of the initial measles exposure, or we can administer immunoglobulin within 6 days of exposure. So who is at risk for measles? People who travel internationally in the last 21 days. This has been historically true, although we are seeing increased outbreaks in the United States and some cases of local transmission. So not all cases will have a travel history. Individuals who are not vaccinated or under-vaccinated. And just a note on that under vaccination. So this may be individuals who have not yet received the full 2 dose for one reason or another. So maybe they started this series, but decided not to get the second dose or are in the process of receiving it and just haven't completed it yet and are waiting the appropriate time until they get their second dose. So immunocompromised individuals, so those with weakened immune systems due to chronic illness or specific medications that they're taking. And then children and infants who are less than 1 year old, and then individuals who are pregnant. So how does measles spread? We know that it is highly contagious and that it's a respiratory illness. The virus typically lives in the nose and throat of the infected person. And the primary mode of transmission is by breathing in droplets when someone infectious coughs, talks, or sneezes. So the virus can also be spread by direct contact with infectious droplets that enter the air by coughing or sneezing, and then those droplets land on surfaces. Someone touches that surface that's been contaminated by the virus and then touches their eyes, their nose, their mouth, and then they can infect themselves. The measles virus can also remain suspended in the air for 2 hours. So it's so contagious that if one person has it, that one person can spread it to many, many others. As we see here. So one of the reasons that we worry about measles is that it is so very transmissible. In fact, one person infected with measles can infect 12 to 18 other unvaccinated individuals. So if we compare this to two other viruses, and I picked influenza and Ebola in this situation. So influenza, or the flu, common virus that circulates mostly in the winter months. And typically, one person will spread that to anywhere between 1 and 4 other individuals. Ebola, a very feared virus, is even less transmissible. In fact, one individual infected with Ebola typically spreads that to 1 or 2 other individuals. You'll notice that there is some variability in these numbers. The transmissibility of viruses can be affected by a number of different factors, including the environment, crowding, and the particular strain of the virus. But the most important thing that we can do to reduce these numbers substantially is through vaccination and other infection prevention and control strategies that we're going to talk about. So let's take a quick peek at vaccine recommendations for MMR. So the MMR vaccine is very effective at providing protection against measles, mumps, and rubella, as well as the complications that are caused by these diseases. So 1 dose provides around 93% protection against measles, and 2 doses brings that up to 97%. So it's a pediatric vaccine. It's typically given the first dose administered between 12 and 18 months of age, and then the second dose is given between 4 and 6 years old. Adults without evidence of immunity should get at least one dose of the MMR vaccine, but certain adults, in particular healthcare professionals, do need 2 doses. And we do this because some adults are going to be in settings that pose a higher risk of measles or mumps transmission, and we want to make sure that they receive both doses separated by at least 28 days. So in addition to healthcare professionals, this also includes international travelers, and students at post-high school education institutions, so universities and colleges. There are a few contraindications to receiving the MMR vaccine. So individuals who are immunocompromised, perhaps they're receiving chemotherapy or long-term immunosuppressive therapy, individuals with a history of allergic reaction to the MMR vaccine, as well as pregnancy. So this is our next poll question. True or false, a person is more protected against contracting measles when they receive 2 doses of the MMR vaccine. Awesome. So everyone who responded got that one correct. The answer is true. Okay. So next we're going to walk through a number of different infection prevention and control strategies for healthcare workers that we can take if there's a suspected or known measles case. So we're going to talk through 7 different steps that are listed here. So the first one, ensure all healthcare personnel are vaccinated against measles. So individuals will need written documentation of MMR vaccine and the fact that they've received 2 doses. We know that the effectiveness of the vaccine is greater when individuals receive both doses. Alternative things that we can look at laboratory evidence of immunity with a positive IgG or laboratory confirmation of having had the disease. If an individual was born before 1957, so before the vaccines were available, we assume that they have immunity through exposure during their childhood. Before the vaccines were available, nearly everyone was infected with measles, mumps, and rubella during their childhood. And so it is likely that individuals born before this period were infected naturally and therefore are presumed to be protected against measles, mumps, and rubella. However, if you happen to be a healthcare worker, healthcare professional born before 1957, and you do not have evidence of immunity to measles, you should consider getting both doses of the MMR vaccine. So we want to try to minimize potential measles exposure as much as possible, especially in the healthcare facility. So, we often get questions about kind of what to do if you're worried about measles. So this is the first step here. So we want to minimize measles exposure. So let's start on the left-hand side of your screen. In the blue box labeled before arrival to a healthcare setting, expected. So this is an expected arrival. The healthcare professional will have a heads up that the patient is coming in. Maybe there was a phone call or you received a message from someone that they're worried about a case of measles and that patient is going to come to the healthcare facility to be evaluated. So really trying to triage the patient over the phone before they arrive in your healthcare facility to get information about their symptoms and as much information about the timeline as possible. If you remember back earlier in this presentation, that timeline is really, really essential. So for persons with signs or symptoms of measles after you've spoken to them, it's going to be really important to provide instructions for their arrival. Remind them to avoid public transportation, ask them to wear a mask if they have one on their way to the facility, and try to minimize the number of people that are accompanying the patient. Give them specific instructions as to which entrance to use and what precautions to take, and let them know what to expect when they arrive at your healthcare facility. So let them know that they'll be given a mask if they don't have one, that they'll be placed in an isolated or private room for evaluation, and that the healthcare worker is going to be wearing specific PPE, such as an N95 and other things. The trickier part is when we don't know that a patient is coming in. So let's look at the left-hand side, or so the right-hand side, the yellow side of your screen. So if the healthcare team does not know that the patient is coming, you really have to rely on your existing triage stations at your healthcare facility for rapid identification and isolation of patients with suspected measles. So reviewing your signs and symptoms. If you're worried, give the patient a face mask. Remind the healthcare professional to put on their N95 and other PPE. And most importantly, isolate the patient away from others as soon as possible. Remembering adherence to things like respiratory hygiene, cough etiquette, hand hygiene, and really relying on your triage procedures to get that patient into an isolated area for everyone's protection. Remember to post your visual alerts, so your signs and posters about the precautions that are being implemented so that other individuals that might be entering the room know what they need to do to protect themselves. And then remind the patient or inform the patient of what to expect while they're there. That individuals are going to be coming into their room, that they're going to remain isolated until we can get more information. If a patient requires transfer to a higher level of care, such as transfer from a long-term care facility or a primary care office to the emergency department, really remind EMS and our rescue services about the precautions that they need to take, what you're worried about, and then notify the receiving facility or the accepting physician in advance prior to transporting the patient so that they can take all of the necessary precautions before the patient arrives. So standard precautions and airborne precautions, many of you are familiar with these. So standard precautions are the foundation for preventing transmission of infectious agents in healthcare settings. Perform hand hygiene using your appropriate PPE, making sure that your PPE is donned and doffed correctly. We have to remember to ensure that our N95 or other respirator is put on properly, covering the nose and mouth, and is snug and appropriately fits your face. Respiratory hygiene, so trying to minimize cross-transmission of respiratory illnesses. And focusing on getting the patient into an isolated room, ideally an airborne infection isolation room. So this is the room that was previously called an a negative pressure room. So this is this particular type of room has special HVAC capabilities to prevent airborne microorganisms from the room from entering into the hallways and the corridors. The AIIR is a single occupancy patient care room that's used to isolate patients with suspected or confirmed airborne infectious diseases. It's really important to make sure that we're cleaning and disinfecting any equipment and the environment within these areas or where a patient with suspected measles has been, and ensuring that our EVS staff have appropriate training on cleaning these isolation rooms, including the cleaning process, the pattern, and what cleaning agents to use. So your airborne precautions, this poster does need to be easily seen outside of the patient's room if you're suspecting measles. So you're going to, again, focus on your hand hygiene before and after entering the room, using your N95 or higher level respirator before entering the room, and then taking it off when you have exited the room. And one of the most important things in the AIIR is that the door has to remain closed for the appropriate HVAC system to work. Just a few other things about your standard and airborne precautions. As we talked about, really getting the patient to the airborne infection isolation room as fast as possible. Wearing a face mask. So while the patient is in the room, if they're there by themselves, they can remove their face mask as long as they are within the AIIR. If an AIIR is not available, it's going to be important to transfer that patient as soon as possible to a facility that does have that capability. While we're waiting for that transfer to occur, place the patient in a private room with the door closed and have them wear a mask. If possible, they should really wear that mask for the duration of time spent in that non-airborne infection isolation room. We do want to try to get a HEPA filter in there to clean the air. And then after the patient leaves that room does need to remain vacant for up to about 2 hours to allow the airborne microorganisms to come out of the air. So healthcare professionals without evidence of measles immunity should not enter the room of a patient with known or suspected measles. only healthcare workers with proof of immunity should be caring for patients with suspected measles. And all healthcare professionals, regardless of whether they've had the vaccine or not, do need to be wearing an N95. So if we're transporting patients from one healthcare facility to another, or even within a healthcare facility, say for testing, we really want to try to limit the transport of patients with known or suspected measles to essential purposes only. Really important to minimize how much time they are interacting with the larger population. So we want to limit this to truly necessary diagnostic and therapeutic procedures that cannot be performed within the patient's room. When transport is necessary, again, put the patient in a face mask, use a transportation route and process that includes minimal contact with persons not essential for the patient's care, and being sure that we're notifying the healthcare professionals at the other end of the patient's impending arrival so that they can take all necessary precautions to prevent any additional transmission. So the duration of airborne precautions, patients with measles should remain in airborne precautions for 4 days after the onset of rash. So as we talked about way back in the beginning, the day of onset of rash is considered day 0. Individuals who are immunocompromised and have measles should remain on airborne precautions for the duration of their illness. Managing visitor access is another challenging topic. If there's individuals with measles within the community, consider screening visitors for signs and symptoms of measles before they enter into your healthcare facility. Visitors without acceptable evidence of immunity should not enter the room of a patient with known or suspected measles. And then limit visitors to patients with known or suspected measles to those who are really necessary for the patient's well-being and care. So that means that we basically don't want a ton of visitors coming into that room because that can increase the risk of spread. Environmental control measures, so standard cleaning and infection procedures are super important. Our EVS staff needs to be using the appropriate disinfectants to apply to frequently touched areas or objects to ensure that they're being cleaned and disinfected appropriately. All right, so managing measles exposure. So we really want to prevent exposure to measles as much as possible, but it may happen. So let's first define an exposure. An exposure to measles in the healthcare setting is considered when spending any time while unprotected. So while not wearing a respirator or an N95 in a shared airspace with an infectious patient with measles at the same time, or in a shared airspace vacated by an infectious patient with measles within the last 2 hours. So if you don't have your respirator on and you are with a patient who has measles, or you enter that room that the patient was in within the 2 hours since they left that room, that is considered an exposure. So if an individual is exposed to measles, we want to determine their measles immunity status. So for individuals who are asymptomatic with presumed immunity to measles, you would implement daily monitoring for signs and symptoms of measles from day 5 after exposure through the 21st day after exposure. In this population, post-exposure prophylaxis and other work restrictions are not necessary. So for asymptomatic healthcare providers without presumptive immunity, those individuals do need to be excluded from work. You would want to offer and ideally administer post-exposure prophylaxis and then monitor for signs and symptoms of measles. Individuals who are exposed to measles and do not have evidence of immunity, patients who are exposed to measles and do not have evidence of immunity should be placed on airborne precautions for 21 days after their last exposure or until discharge if earlier. You would want to administer post-exposure prophylaxis as well as notify healthcare authorities about these patients who have been exposed when they're discharged so that the healthcare and the health authorities and the public health team can follow up with them after they leave the facility. So considerations to take into account if there is a measles outbreak. In the event of an outbreak or exposure involving a large number of patients who require airborne precautions, it will be important to consult infection control professionals within your facility before arranging for patient placement to determine the possible safety of alternative rooms that maybe do not meet the strict engineering requirements for airborne infection isolation rooms. So this may require special cohorting of patients who have confirmed measles in areas of a facility that are separated from other patient populations, or using temporary portable solutions, such to kind of create additional negative pressure rooms. So talking about education and training. So healthcare professionals should be sure to get job-specific education and training, such as today's webinar, to remind them about the things that they need to do if there is a measles outbreak or measles cases. Making sure that people undergo specific fit testing to make sure that their N95 masks are comfortable and provide the appropriate protection while they're wearing it. Healthcare providers typically undergo fit testing annually to ensure that the respirator continues to fit properly, because each brand, model, and size of respirators will fit differently. Healthcare providers do need to be refit tested if there's a change made to what type of model or sizing that the facility is stocking. Additionally, if the healthcare professional has significant weight changes or facial or dental alterations, a fit test should be done again to ensure that the respirator remains effective. All right, and so the last thing really is to connect with our public health authorities. So in Rhode Island, this would be the Rhode Island Department of Health, and I'm going to give you in 2 slides some additional information about the resources available at RIDO. But we really want to focus on implementing policies that alert the key staff and leadership as to what's going on, right? We want people to know so that they can protect themselves if there is an increase in number of measles in the community, and if those individuals are at our healthcare facilities. So communication and collaboration with our public health authorities is essential. We want to make sure that we are notifying public health authorities of patients with known or suspected measles, and really having specific individuals to communicate and collaborate and disseminate information within the facility is going to be essential. So to summarize the 7 steps that we talked about in the last few slides, these really fall under 3 main ideas. So identifying patients who are at risk, rapidly assessing our symptoms, so their age, travel history, vaccination status, if they've had any exposure or contact with individuals who have been diagnosed with measles, right? So that identification is step 1. Isolation, so isolating the patients, wearing masks, placing patients in airborne infection isolation rooms, using our appropriate PPE and N95s, and then informing and communicating with the Department of Health, as rapidly as possible. For healthcare providers in Rhode Island, the Rhode Island Department of Health does need to be immediately notified about any suspected case of measles to ensure rapid testing and investigation. So measles is an immediately reportable disease here in Rhode Island, and we're going to go over how to get in contact on this slide. So the Center for Acute Infectious Disease Epidemiology within the Department of Health is who helps here within Rhode Island gather information about suspected measles cases and kind of coordinates all of the testing and follow up with the patient. So one of the most important things that all of us can do before calling RIDO is to gather all of the information, or as much of it as possible, about the patient and their symptoms before making the phone call. So this would be name, age, immunization history, travel history, their measles exposure history, and really getting as much information about their history of the illness and the timeline, as specific as possible, right? In addition to other things about their pertinent medical history that might be important. The Department of Health does need to approve testing prior to samples being sent to the state health lab, which is where all of the measles specimens should be sent. But we really want to make sure that we have all of that information to give to the Department of Health so that we can have a good informed conversation about the likelihood of this being measles and the next steps that we're going to do. Gathering all of this ahead of time does a few things. One, it'll streamline that conversation, but two, it minimizes the risk of that healthcare worker needing to go back and forth into the room or having someone go in there to get that information, which could potentially increase exposure. One of the other things is really thinking about what your differential diagnosis is. If you're a healthcare worker calling concerned about measles, what else might be on your list? And being able to have that conversation with the Department of Health can really make that phone call as valuable as it can be. So on this slide, we have the information about the phone number where you can call to get help and ask questions. And we put the link in the chat as well. So you could print out this handout if you would like and give it to any other healthcare workers in your facility. All right, we have 2 more poll questions before we're done. So if you suspect someone of having measles, should you isolate that person promptly? Yes or no? Awesome. Correct. The answer to that one is yes. And our next poll question, what precautions should be used when caring for a person with measles? Standard and enhanced barrier precautions, standard and droplet precautions, standard and airborne precautions, standard precautions only. All right, so the answer for this one is C, standard and airborne precautions. I see a few people did select B, which is standard and droplet precautions. Remember, the thing with measles is that those organisms can remain suspended in the air for prolonged periods of time. That is why we need to place patients with suspected or confirmed measles in the airborne isolation rooms, and why our healthcare providers need to be wearing respirators or N95s, as part of that airborne precautions. Okay, so we have 2 scenarios that I just wanted to talk through before we end today, and I invite you to put all of your answers in the chat. So here's our first case scenario. A 23-year-old male arrives to the emergency department with complaints of fever, cough, and watery eyes that started at the end of his college spring break. The healthcare professional noted small raised spots at the patient's hairline. What are some immediate questions that the physician or the healthcare provider should ask the patient? Give everyone a minute to put some comments in the chat. Excellent. Any sick contacts, recent travel? When did their symptoms start? Good vaccine status. All right, our prompt in this case talks about him going on spring break. So where did he travel? Right. And what are some infection control actions the healthcare provider should take? Okay, I see people mentioning PPE. What kind of PPE? Good, N95, perfect. So that'll be for your healthcare provider. Gown and gloves, excellent. Isolating the patient. Good. And remember, we want to get a mask on him as well, right? Doesn't need to be an N95, but just a regular mask for him. Ideally getting him to an AIIR or at least a private room. Good. All right, case number 2. So here's our second scenario. So a mom calls the pediatrician's office to report her 3-year-old daughter has a fever of 105, accompanied by a cough and a runny nose. She reports that her daughter's symptoms started a few days after they returned from Disney. What are some of the telephone triage questions that we can ask the mom? Good vaccination status, right? So she's 3. So she should have already gotten her first dose of MMR, may not have her second. If there's a rash, wonderful, and what it looks like. Technology is great these days. We can take pictures of these rashes and sometimes upload them to the medical record system or get them to the healthcare provider for review. Any recent contacts that were sick, excellent. Symptoms, travel, vaccination status, perfect. So, one of the things with Disney, right, is that Disney attracts people from all over the world. And there's actually been a number of measles outbreaks related specifically to visiting Disney World and Disneyland because of how many international travelers and how many people are kind of mingling in those close areas. Good. So what pre-arrival instructions should we give, should the healthcare provider give to the mom before they come into the office? Good. No public transport, put on a mask, right? Probably the mom and the kid, ideally. Um, bring them to a separate room. Potentially come in the back door. Yeah, good. Calling on arrival, thinking back to what we did during COVID, right? Wait in our cars, we would call into the office, let them know that we're there. That way they could make sure that they had a specific room to bring the patient to immediately. Yeah, and trying to make sure that we're going to a facility that could accommodate the isolation, right? Depending on how concerned you might be, right? That's where getting that really clear history about what's going on is super important because that'll help you figure out, is measles on your list, but way down, kind of in terms of things that you're worried about. Um, Something else much more likely. Good. Thanks for contributing, everyone. We only have about 2 or 3 minutes left. So transitioning, just quick review of our key takeaways. So things that we talked about kind of ad nauseum today. Measles is highly contagious. It is a febrile illness, right? So fever is an important part of that history. We've got to have a fever. And it can cause serious complications and may result in death. Identifying measles early is critical to preventing its spread. We really need to focus on vaccination. That's the single most important thing we can do to decrease measles cases. Suspected measles cases should be masked and isolated while their medical evaluation is being performed. And healthcare providers need to follow standard and airborne precautions when caring for individuals with measles. So these are some resources available from CDC. They are posters that can be downloaded and printed off for your staff. Poster on the left talks about identifying a rash and how to protect against infection. On the right, this is a great summary of key points regarding measles, as well as some images there for help identifying the rash. And there's a link in the chat for accessing these resources. We have some upcoming future sessions, different trainings available, and you can follow us on Twitter, Facebook, and Instagram, as well as YouTube. Our next session is going to be on April 6th. This is source control and PPE refresher. So there'll be a CE, CNE, and certificates of training will be offered for all these sessions. You can pre-register, and Abby will show the link to do so. We hope to see everyone there. These are our references for the day. And then just a quick note on our certificates of training. So in order to receive your certificate of training and any CNE, complete the post-session survey, and quiz. So this is going to be sent to you tomorrow. The post-session survey and quiz close at midnight on March 30th, and then the certificates of training are going to be sent out on the 2nd. Reminder that there is the post-session quiz that's required for certificates, nursing education, and those will be emailed out tomorrow as well. So quick end of session feedback poll should be appearing on your screen. Take a minute to complete that, and then we will wrap up. Awesome. So we will be sharing all of these resources via email. I don't see any questions in the Q&A box, and we are at time. I don't want to hold anyone. I know you have busy afternoons, so feel free to reach out to us with any questions. Always happy to help. And of course, if you are concerned about measles in any of your patients, don't hesitate to give the Department of Health a call. We have a lot of great resources that can help you. Thanks so much, everyone. Enjoy the afternoon.